So good morning, everyone. I'm Dr. Lino, presenting on behalf of Medicine Tree. Presenting Mr. X, 71 years old gentleman from West Bengal, presented with chief complaints of recurrent episodes of bleeding from nose for last 15 years. He was apparently well before 15 years when he developed recurrent episodes of bright blood spontaneously coming from his nose. Initially 1 to 2 episodes in a month. Now the frequency of episodes has increased for the past 3 months, for 6 to 6 episodes per month. Over the last 3 months, he was admitted in nearby hospital thrice and received a total of 6 blood transfusions. No history of any bleeding from any other site, or no history of any recurrent nose picking. Past history wise is an old pulmonary tuberculosis patient with residual lung damage, took ATT for 6 months. No history of hypertension in past, no history of any dust allergy, or no history of any head and neck surgery in past. Family history, there is no history of similar illness in any other family members. Personal history wise, there is no addiction. Appetite was normal, and his bowel and blood habits were normal. Medication history wise, he was not on any antiplatelets, anticoagulants, and NSAIDs. The examination, he was alert, conscious, and oriented. Vitals, everything is stable. Palo was present at the time of admission. Cutaneous examination was normal. Right and local examination, right nose and left nose were normal. Respiratory system wise, trachea shifted to right and bronchial press zones over right intra-axillary area. CVS examination normal and per abdomen was also normal. Central nervous system examination wise, cranial nerve examination normal. Motor system examination is also normal. Deep temporal reflexes 2+ in all everywhere. Plantar bilaterally it is flexus and cerebellar signs were negative. At this point of time, some elderly gentleman presented with chronic history of painless spontaneous epistaxis, which is worsened over 3 months. The differential considered were some local causes like nasal tumors and nasal polyps, and other systemic causes like some coagulopathies, hypertension, and vascular malformation. Baseline investigation showed HB of 7.9 gram and MCV of 80.8 and MCHC of 30. His transferrin saturation was 8 and vitamin B12 and folic acid levels were normal. So coagulopathy workup, the platelets were normal, PTA and APTTA and everything was in normal range. This LFT was also normal. So for evaluation of anemia, we did bone marrow biopsy. It showed cellular marrow with features suggestive of iron deficiency and even no abnormal cells. So to rule out any skull-based tumors or aneurysm causing this recurrent episodes of epistaxis, we did MRI base of skull with gadolinium. Mucosal thickening of left maxillary posterior ethmoidal hemisphenoid sinuses and no focal lesions were noted. And we went ahead with the rigid nasal endoscopy. It showed multiple dilated small vessels suggestive of telangiectasias in the nasal cavity. Now, the elderly man presenting with recurrent episodes of epistaxis and iron deficiency anemia with evidence of telangiectasia, the possibility we came is the inherited vascular malformation, hereditary hemorrhagic telangiectasia. Hereditary hemorrhagic telangiectasia is also known as Osler-Weber-Rendy syndrome. It's an autosomal dominant disorder due to mutation in gene encoding for TGF-beta receptor leading to development of multiple AV malformation. The most common symptom of hereditary hemorrhagic telangiectasia is epistaxis. These AV malformation not only present in this mucosal membrane, it can also involve other organ systems including lungs, gastrointestinal tracts, liver, and brain. The diagnosis is based on the Curaco criteria and genetic testing. The Curaco criteria is nose bleeds spontaneous and recurrent, and telangiectasias multiple characteristic sites including lips, oral cavity, fingers, or nose. And other internal lesions such as gastrointestinal telangiectasia, pulmonary AV malformation, hepatic AV malformation, cerebral AV malformation, and spinal AV malformation. In addition to that, the family history of first degree family relative with HHT according to this criteria. For someone to be diagnosed with hereditary hemorrhagic telangiectasia, he should at least have 3. For definitive diagnosis, 3 criteria should be present, and possible suspected 2 criteria should be set. If it is less than 2, it is unlikely to be hereditary hemorrhagic telangiectasia. In our patient, she had recurrent episodes of nosebleeds, which is spontaneous, and we found evidence of telangiectasia in nasal cavity. For screening other vessel observable involvement, we did UGA scopy. It showed a vascular blood in the esophagus. CT thorax didn't show any evidence of AV malformation or hepatic malformation. In the MRI brain also we did. There is no evidence of cerebral AV malformation. So he had 3 features fitting in this criteria. Also, if for confirming the diagnosis, we can do pathogenic sequence variant in genes